Hello, thank you for tuning into the Natural Health Rising podcast. My name is Rachel Smith. I am a certified functional diagnostic nutrition practitioner, and I've helped hundreds of people naturally reverse symptoms of autoimmune diseases and other health challenges, from digestive issues to hormone imbalances. And in these weekly episodes, you're going to learn from myself and top health experts from around the world about functional medicine and holistic health tips to help you rise to your healthiest, happiest self. On this episode of the Natural Health Rising podcast, I have Dr. Aslie with me. Dr. Aslie is a board certified spine surgeon who received his undergraduate education at the University of California, Berkeley, where he double majored in physiology and genetics. He earned his MD from New York Medical College and completed his residency at St. Vincent's Hospital in New York City while working with some of the world's most renowned scoliosis surgeons. He received his spine surgery fellowship training at Harvard University. In addition to his private practice in California, Dr. Aslie has been active in researching and developing cutting-edge treatments for osteoporotic and aging spines. Welcome to the show, Dr. Aslie.
Thank you very much. Thank you very much for giving me a chance to be here.
Of course. I'm excited to talk all about back pain, spines, all of these different things today. So why don't you start off by telling us the people who, there's so many people who complain of back pain. And out of the people you see coming into your office, what's really going on? Like, are there different root causes for this pain people are experiencing?
Oh, that's a very good question. First, I want to explain a little bit of anatomy. The spine is composed of a bunch of bones, we call vertebral bones, that are stacked up on top of each other. Each one of them separated by the bone above and below with a cushion that we call it disc. It's a part of a cartilage. This disc is a cartilage that has two components, the inside mushy gelatin stuff and the tough ring around it. Beside that, the vertebrae connect to each other with a three-point contact. In the front is the disc. In the back, there are two joints that form what we call facet joints with the bone above and below. Now, when I started my practice, my perception was that, man, there's so many moving parts. Spine, after all, is a mechanical device. It's a very complex mechanical device. So there's so many moving parts, so many muscle attachments, and so many things, therefore, that can go wrong. So beginning of my practice, I was like, maybe we just don't see what is, for all the stuff that's going on, what's going on. Well, let's go back. The imaging study that we have for spine is what we call MRI. MRI looks for water. Water is light, darkness, dry. So in a way that, invention of MRI was actually beginning of spine surgery, because before that we couldn't see these discs. But then after that, with MRI, we can start seeing these discs and see what's going on. So what I'm about to tell you, and the answer to your question after all this introduction, is very speculative type of a thing. We truly don't understand where the back pain is coming from, what structure, how, and then what happens after that. We just don't know. So beginning of my practice, I used to think that, well, there's so many people with back pain that MRIs are negative. So there must be something that's not coming up in MRIs, or is it different structures like muscles, like facet joints or so. However, I want to say that after 20 years of practice, I'm going back to basically disc being the culprit in the majority of the times. I think I'm settling down that it's really the disc. And in patients that the MRIs are negative, I still think it's the disc, except that damage is not bad enough that the MRI can pick it up. So, of course, this is something that 10 years, 20 years from now might change my mind with more data coming out. But at this point, I would say the most commonly injured structure that causes debilitating back pain or so is the disc, is the cushion that are between the bones that gets injured one way or another and then causing the pain.
Okay. Yeah, I'm sure a lot of people can relate to that. I myself have had a herniated disc. It is not fun.
Is that so? Wow.
Yes, yes, from a car accident. So we'll get all into the spinal surgery info, but what are non-surgical routes to addressing back issues?
Sure. So what I tell my patients, and I give this lecture to every patient that I see, treatment of back pain normally falls into three stages. The first stage is what we call manipulative treatments. The whole idea is to manipulate the body with one technique or the other and try to get them better. In that category, you have chiropractic care, physical therapy, acupuncture, massage, yoga, Pilates, you name it. It's a whole world by itself. And my preference is mostly chiropractic care. I'm a different type of a surgeon. If you go to other spine surgeons, they're not sure about physical therapy and chiropractic care, but I have a practice that I focus on non-operative treatments quite a bit. And what I've come to learn is that I believe chiropractors have upper hand compared to the physical therapists in terms of manipulations of the spine, therapeutic manipulations of spine. Why? As an orthopedic surgeon, we get quite attached to physical therapy. So physical therapy is the first thing that we refer patients to. The problem is that physical therapy works really well in extremity, in the joints, wrist, elbow, shoulder, hips, knees, works great. Why? Because to see what works and how it works, we got to kind of step back again and see where the pain is coming from, how the pain is produced. Pain is produced by inflammation. When an area is inflamed, increased pressure causes increased pain. And then if we decrease the pressure in that area or stretch the area, that's when the pain gets better. So let's say if you have an injured knee, there's some inflammation in the knee. By stretching exercises, what you're doing, you relax the area and decreasing the pressure, and hopefully the pain is getting better. That's the understanding of what we have of the pain generation. Well, the problem is that physical therapy is very good in terms of stretching ligaments and tendons in the joints with range of motion exercises and stuff like that. But when it comes to spine, the structure that's affected, which is disc, is very deep, and you just cannot stretch that. You cannot decompress it by manipulations, because to do that, you have to put the patient in an extreme range of motion, and just patients don't tolerate that. Therefore, I believe when it comes to the back pain, initial stage of the back pain with manipulative treatments, chiropractic care has an upper hand because they can do those stretching and decompression of the inflamed area with manipulations that the patient can tolerate, as opposed to try to stretch it with maneuvers that the patient might not tolerate. So that's one thing that I say I'm very keen on, actually, chiropractic care. So that's the first step. Second step, what we call therapeutic injections, and I'm going to get back to that. Third and last step is surgery, and that's where I come. Now, I want to say that when it comes to surgery, almost 95+% of my patients in my practice, the indication for surgery is pain. They come to me because they have pain, either neck pain, arm pain, low back, and leg pain. Well, problem with imaging studies is that I cannot look at the MRI and say how much pain the patient is in or what's going to happen to them. The way I explain it is that damage does not equal pain. Damage plus inflammation equals pain. And really, it's the inflammation that causes the pain. That's why you have good days and bad days. The MRI doesn't change. You have a good day, you do something that is inflamed, and you have a bad day. And the problem is that we have no study to figure out where the inflammation is or to what extent. So what I'm trying to say is that in my world, looks don't matter. And that's the first thing that always patients ask me: how bad does it look? Back pain, damaged disc is not like a tumor that the bigger it is, the bigger the problem. No, I have patients that they have a horrible looking discs, like worn, bone on bone, and they're like, I'm fine. I was pretty miserable when I made the appointment. By now that I'm actually seeing you, which is like a couple of weeks later, I'm actually feeling better. And I have patients that they have MRIs, just like barely something there, like a little tear, and they're like, they can't even breathe deep because they're in so much pain. So what I'm trying to get at is that when it comes to the surgical treatment, who needs surgery, who doesn't need the surgery, it comes from the patient. Patient knows how much pain they're suffering and how much they can tolerate. So I tell my patient, I said, if you think you don't need surgery, that means you don't need surgery. However, if you've come to a point that you can't live like this anymore, that's the time that we should intervene with surgery. So, because a lot of time patients come in to see me and they're worried, they're all scared. They think like because they've been told by their friends or so that, oh my God, he's going to say that you need surgery. And I tell them, no, no, no. The need for surgery comes from you. My job as a surgeon is only tell you if I can help you or not. That's it. So that's the surgical part. Now, I would like to go back, talk about the injections and procedures now. So let's say you have back pain, you've done some chiropractic, you went to your local chiropractor, you had some chiropractic care. If you're better, you're good. If you're not better, then you got to decide, is this bad enough that you want to go to the next level? If you say, no, I'm going to live with this, I'm going to modify my activities a little bit, then that's fine. If not, then we can proceed to the next step, with those procedures. Now, when I talk about procedures of the back, I overall divide the procedures into two categories. Procedures that are based on cortisone and then everything else. Why? Well, because as I discussed earlier, it's the inflammation that causes the pain. So inflammation is root cause of the pain. So everything that we want to do, we want to stop inflammation, basically. Well, cortisone is the only medicine that we have available for us that we can actually reduce the inflammation. Cortisone is an anti-inflammatory. We produce cortisone in our body. It's produced in a gland called suprarenal gland. It's a small little fatty tissue that sits above the kidneys. And cortisone is produced by that. It's a natural hormone, and it's a hormone that fights inflammation. So its job is anti-inflammatory. So cortisone is the only medicine that actually has a chance of getting to the root of the cause and eliminate that problem and basically get you back to where you were before. After cortisone injections, everything else, by definition, is a temporary, if it works for you. And reason for that is that beside the cortisone injections, the procedures that we have, which I discuss later, is there to improve your symptom and not correct the problem in a way. Now, when it comes to steroid injections, unfortunately, steroid is a very elusive type of a medicine. Sometimes works a little, sometimes does not work at all. As a matter of fact, I tell my patients that same doctor can inject in the same spot with the same medicine twice, and you'll have a two completely different experience. And that's the rule, not an exception. So in a way, cortisone does not work like a medicine. It works and is a hormone. Well, that's good and bad. Bad is that it's very unpredictable. When you take a medicine, like a pain medicine or something, you know exactly what's going to do every time you take it, like a blood pressure medicine or pain medicine. That's very predictable. So if the patient tells me what's going to do, I can tell him exactly what's going to happen. When it comes to cortisone, it's the roll of a dice. Sometimes you got 6, sometimes you get 1, sometimes you get 3. We just don't understand it. So that's unpredictability is the negative side of cortisone. But there's a very positive side to the cortisone that we have to understand that. And that's the power to actually eliminate the problem. So we really don't have any medicine that can eliminate the problem. Every medicine that we have, you don't take a pill and all your problem goes away. Great majority of the medicine is something that, eliminate the symptoms, but then probably you have to take more down the road. But cortisone, as I said, acts like a hormone, has the power, even though it's unpredictable, but has the power to eliminate the problem completely. Now, what I tell my patient is this. Normally, cortisone follows the rules of 3. 1 out of 3, it doesn't do anything. 1 out of 3, it works, but it's temporary. And it could be anywhere between 1 week to a few months. But 1 out of 3 takes care of the problem. That means eliminating the pain. And that's why we use cortisone. Because a lot of my patients come into my office and say, Dr. Aslie, we heard it doesn't work. Dr. Aslie, we heard that it's temporary. And my answer is yes, all of the above. Plus, 1/3 of the patient, it actually eliminates the pain. And that's why we use it. So that's the use of cortisone. That's what we use it. Now, of course, there are different ways of administering cortisone, and that's basically how deep do you go. Overall, I divide the cortisone injections into two categories. One, a series of injections that goes on the bone. So they go through the muscle on the bone. And these injections are what we call facet blocks or medial branch block. These injections go on the bone. The other type of injection go deeper under the bone around the nerve. So that's the deepest that they can go. And epidural injection is an example of deeper injections. Now, of course, the question is which one is better? Well, we don't know. According to research, both injections, the one goes on the bone and the one goes under the bone, they work pretty much the same. They have the same efficacy. So in my practice, I start with the simple injection first. And if that doesn't work, then we can try the deep injection. So to summarize the back pain, we do therapy, chiropractic care, physical therapy, whatnot, whatever you prefer. That doesn't help, then we try injections. We try steroid injections. If that works for you, great. If it doesn't work for you, then patient has a decision. They can either say, I want to proceed with surgery, or if their pain is not bad enough for a life-changing surgery, then we have procedures like radiofrequency ablation or Botox injections or so that are temporary, but can help the patient quite a bit. And of course, at any moment, if the pain turns into a problem that patient cannot tolerate, then we proceed with surgery at that time. I hope that helped you in terms of how we manage the patients.
Mm-hmm. Yeah, no, that makes a ton of sense. Is there damage that can be done with too many cortisone shots?
Yes, absolutely. Problem is that we have nothing else. There's really nothing else. Cortisone is a hormone, so repeated injections can cause your hormones actually kind of get out of whack. Plus, the other thing is that when I have some patients when I do surgeries, they've had too many cortisone injections. So when it's the time for me to go ahead and do the surgery, when I go there to, let's say, decompress the tissue, I face a whole bunch of scar tissue. So the cortisone can cause scar tissue, which makes my surgery a lot more difficult, which in turn, what that means is that the patient is in more danger. And at the same time, I cannot do a complete job. If everything's plastered together, it's going to be very hard to remove the scar tissue that's attached to the nerve. So cortisone injection is definitely something that it's a safe medicine, but it's not a medicine that you can have like a pain medicine that you can have over and over and over and over. And that rarely happens. What happens normally is that it either works or it doesn't work. If it works, we're good. If it doesn't work, we're done. So the number of patients that actually cortisone works, let's say 6 months at a time, 5 months at a time, that they need repeated cortisone injections throughout time, we don't know what numbers, but they exist, But yes, cortisone injection is not something that it is safe. My mom has had 12 of them over like 10 years, but it's not something that you can carefree. You can just keep injecting forever.
Right. Okay. Can you tell everyone how medical device companies are making billions of dollars off of spinal surgeries with little proven effectiveness?
Oh my God, that's what my book is all about, actually. It's, as you know, I wrote my book, Corporate Spine, and it's all about this issue that you brought up. And it's pretty bad. What happens is that in the world of spine surgery, now, one thing I want the audience to understand is that spine surgery is a very young field. We were doing, some people might argue that we've been doing spine surgery since turn of the century. It's true, we've been doing scoliosis surgeries or so, but it wasn't until invention of the MRI that we actually were able to see these discs and figure out actually what we were doing. So if you think about that, MRI, the first commercially available MRI was in 1985. So the first MRIs were not that good quality. So let's say 10 years it would take for the technology to get better, and then another 10 years for the MRI to be distributed all along the country. You know, the first time when the first MRIs come out, and only the big medical centers have it. So let's say if it came out in 1985, let's say even in 10 years, 1995, that we started really having these MRIs that are good quality, we can see. So from 1995 till now, we're talking about only 25, 27 years. That's not a lot of time for us to come up with a lot of answers to all the questions. So that's one thing that I want my patients to understand, that it's very important. We're working hard, but we have a lot of questions that we need answers to. So, however, what happens is that spine surgery is, when we do spine surgery, there's a lot of equipment involved, a lot of devices. After all, as I said, spine is a mechanical device. So sometimes to correct it, we need medical metallic prosthesis, implants. The problem with that is this, and it's rampant. A company comes up with a product, then they approach a surgeon, and it's always a famous surgeon. They're not going to approach somebody sitting in some small town somewhere in the middle of America. They approach somebody who's in a high level of educational center, Harvard, Johns Hopkins, or whatnot. And then that surgeons start writing papers that are favorable to those products. Then we start using those devices, and then 10 years later, we find that this stuff didn't work. Nobody says anything, and then goes on to the next product. And that's not right, because in that 10 years, what happens is that by these falsified research, made up numbers, the whole world of spine surgery starts going in the wrong direction. And a good example of that is a device called pedicle screws. Right around when the fusion surgery was becoming popular, right around 1985. So let's go back and explain what fusion surgery is. We learned that actually it's the disc, the cushion between the two bones, that can go out, wear out, get damaged, and cause pain. We said, well, to treat that, we got to take the disc out and fuse the two bones together, eliminate the motion, and then eliminating pain. And we started doing these fusion surgeries, and they worked pretty well. However, we had this thing called non-union. 1 out of 4 patients, which is not small, did not heal the fusion. The bones didn't turn into one bone. And that's a big problem, because now the patient is going to have more pain. So to increase the fusion rate, we came out with large screws. There are screws. This is an example of it. It's a pedicle screw. This is a large screw that gets inserted into the vertebrae from back to front. So if you look from the back, you put these screws on each side of the vertebrae, and you put them in the number of bones that you want to fuse. And then these screws have a tulip that can accept a rod. So let's say you want to fuse 5 bones together. You put 10 screws, 1 on each side, and then sequentially you connect them with a rod, and they connect to each other. Basically, that stabilizes the spine. So hopefully the fusion will take place. When these screws came out, it was a lot of surgeons were very skeptical, because there were a lot of bad results. At some point, there were 7,000 lawsuits against the manufacturing of the screws, a company called Medtronic. There were about 500 lawsuits against North American Spine Society and American Academy of Orthopedic Surgeons, right around early 90s, like 1990 to 1995. Well, at that time, a surgeon called Dr. Zdeblik published a paper in the Spine Journal and said that these screws work beautifully. According to this paper, addition of the screws made a huge difference in terms of patients' outcome and the fusion rate. So when he published that paper in 1993, basically that gave us the green light to use these screws. And using these screws became actually the standard of care. Starting from 2000s on, everybody gets a fusion, get these screws, to a point that if you don't use the screws and there's a problem, you go to another surgeon, that's the first thing that they're going to point their finger out. It's like, oh, the guy didn't use screws. That's why you have a problem. Mm-hmm. So basically, that's what we use all the time. Problem is that between 1997 and 2004, 6 independent, multi-center, multinational papers came out and said, these screws don't work. They don't increase fusion rate and they don't improve outcome. So when I found this out, when I was doing my research and development, when I saw these papers, I was like, wait a minute, what is going on here? There is this wealth of information, multi-center, multinational papers saying that the screws don't work. One guy says that it works beautifully. So let me look into this a little bit more. So I started digging deep into the literature. First thing that I noticed was that the paper that Dr. Zdeblik published in 1993 was published as a preliminary report. I spent about 2 years to look for the final report. I looked everywhere. I talked to the professors. Eventually, in one of the meetings, one of the professors told me that that study was abandoned in the middle, was never finished. That preliminary report is the only thing that we have. When I heard that, my jaw dropped. I was like, what? That's it? If you Google right now, name Zdeblik, by the way, he is the chairman of orthopedic surgery, spine surgery in the University of Wisconsin right now. If you Google his name, you will see that this paper comes, Zdeblik spine fusion. You see this paper comes out. And this paper, even though it's a preliminary report, has been referenced in 1,124 articles. I mean, I just couldn't understand it. Not one of these authors asked the question, where's the final report? I mean, is the scientific criteria is so low that a preliminary report will satisfy the completeness of being the experiment being complete? I mean, that's just terrible. So I said, let me look at Dr. Zdeblik a little bit more. And every time I thought things cannot get worse, it got 10 times worse. So he publishes this paper in 1993. Starting in 1996, he started getting paid from the company that manufacturing these screws. By 2003, he got paid $34 million. I mean, that's a very large amount. I was like, wow, this looks bad. Sounds like he published the paper, now is getting paid. As the lawsuits against the manufacturer were dropping out. So he publishes a paper in 1993. By 1996, as the lawsuits were disappearing, he started getting paid. Then something even worse happens. So Medtronic is a big company, and they had this other product called BMP, bone morphogenic protein. Every time we do a fusion surgery, we have to put bone chips between the two vertebrae, between the two backbones. So hopefully the bone chips will turn into a solid bone. Well, where do you get those bone chips? You have to harvest it from somewhere else. Problem with that is that now that place that you harvested becomes painful. So trying to fix this surgery, now we've created a new problem. So we were trying to avoid bone grafting as much as we could. So Medtronic came out with this product called BMP, bone morphogenic protein. It's a hormone that we all have it. When you break your bone, it gets excreted, and that's how you heal the fractured bones. Well, Medtronic was able to isolate this and brings it as a product. So this product appeared like late 90s or so. So everybody was asking, does it work? Doesn't work. Well, Medtronic put who in charge of this study? Dr. Zdeblik. So Dr. Zdeblik was the main author that was involved in evaluating in BMP. Guess what happened? He published a paper in 2004 stating that BMP works great. But this is what happened. There was an investigation by who? By United States Senate, of all the people. So nobody can argue the relevance of this investigation. It was the United States Senate conclusion that that paper that was published in 2004 by Dr. Zdeblik was not written by him, was written by the company's marketing department. Is that crazy? That's just
Wow.
crazy.
That is insane.
That's like insane. Not only that, this is just the tip of the iceberg. There's another thing that people don't understand, they're not aware of. Dr. Zdeblik was a chief editor of a major spinal journal from 2002 all the way till 2019, the spinal disorders. I mean, never in the history of medicine, a company has had such a direct access to literature of a subspecialty. This is just crazy, you know, and 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 something needs to get done. This is just bad. Uh, to make things worse, you think that's bad? No. Every time you think like, can it get worse? It gets worse. In 2018, there was another very important study that we were waiting for. This was a study that was conducted for about 8 years. It's a very important follow-up study. This study was published in 2018. What do you think that study concluded? That study concluded that addition of the screws did not alter the outcome of the surgery. So now, 2 decades later, same result. Now, the question is, I know these are some of the questions that the audience will ask me. Have you brought this up with the leaders of your field? Absolutely. I'm not a keyboard warrior. I'm not here just writing email. I go to these conferences and I confront them. I follow them. I chase them. I ambush them. And I'll tell you exactly what I've heard in terms of the answer. If you tell so-called leaders of the field, well, what is this papers? There's all these papers against the screw. They'll tell you this. Yes, we know, we are aware that we have not been able to show with research that the screws work, but we will in the future. And my response is like, wait a minute, that's a definition of insanity to do the same experiment over and over and hoping that one of them will give you the outcome that you desire. That's just crazy. Plus, every time you fail to show that something is working, you have just shown that it didn't work. These are not two separate events. All these papers that showed they don't work, they've actually shown that they failed to show that it works. They've shown over and over that screws don't work. So what is the problem? What is going on? That's the big answer. And I spent about 3 years look for that answer, and I found it. But it took me 3 years to get that. And this is how it goes. Spine surgery is a subspecialty of orthopedic surgery. We become orthopedic surgeons first. We spent about 5 years to become orthopedic surgeons. And in that 5 years, our exposure to spine is very low, very nominal. Everything that we study is about fracture. Every time we're on call, broken bones. So we do that for 5 years. Then we do, the ones that want to do spine surgery, we do 1 year in fellowship in spine surgery, and we call ourselves spine surgeons. So guess what? Everything that we learned in orthopedic surgery, it comes from fracture fixation, which there's a concept called rigid fixation. In 1960s, when we wanted to treat fracture, a group in Germany realized that if you put the two ends of the bone together in a rigid fashion, that's the best chance of the bones healing together. We call it AO technique. So rigid fixation showed very well that the bone healing needs stabilization. And we practice that, what we do in a fracture fixation. Guess what? Well, as orthopedic surgeons, for 5 years, it gets hammered into our head that a rigid fixation is the answer. So we got that knowledge. So when we became spine surgeons, we brought that same knowledge into spine surgery and applied that exact knowledge to spinal fusions. But this is the problem. The concept of rigid fixation works in general orthopedics, extremity, like arms and leg fractures, for one important reason. In the extremity, you have the option of eliminating gravity. In the arm, of course, patient's in sling. In the leg, you put the patient on crutches. So you can tell him not to wait there, basically, on that leg. You eliminate gravity. In spine, you can't eliminate gravity. You cannot hold the patient in the air for 3-4 months at a time. Mm-hmm. So that the second the patient gets up from bed, that construct is under tremendous amount of stress. And it's the same concept of building high rises in an earthquake zone. Like when you go to San Francisco, they don't make those tall buildings stiff. They make it flexible. So if there's an earthquake, it can move and dissipate the energy as opposed to crack and just fall down. Same concept. So when you go from extremity fixation to spinal fixation, you go into a completely different world. The way I explained is very similar to quantum physics and Newtonian physics. In Newtonian physics, you got gravity, force, action versus reaction. You know, basically, if you want to build a house on Earth, you can use Newtonian physics. But if you want to shoot a laser or send a rocket to the moon, Newtonian physics don't work anymore. You need a new principle called quantum physics. Same thing. In spinal surgery, you learned everything you learned in orthopedic surgery, that the rigid fixation worked very well. But you apply that concept to spine, it doesn't work. And the research clearly says that. So basically, what I'm trying to say is that spine surgery was never meant to be a subspecialty of orthopedic surgery. You know, spine surgery is a completely different world by itself. There's nothing in orthopedic surgery that's going to make you a better spine surgeon. Nothing. I can tell you right now. I mean, the disc that we have, the disc structure that gets injured, there's nothing close to it, nothing similar to it in general orthopedics. It's a very unique structure to spine. So what the problem is that we made a mistake from beginning. Spine surgery should be a specialty by itself. Whatever you learned in orthopedic surgery, you got to unlearn it and relearn everything that's specific to spine. That's the problem. So, you know, I for the longest time, I kept asking myself a question. Is it, are we crooks? Are we like surgeons and they become crooks? We just kind of put ourselves for the highest bidder in these companies. Some people, they do that. But most of us, is the fact that we've been trained a certain way and the training was not adequate. That's why. I mean, right. when I approach spine surgeons and I say, and I give them, you want to hear a funny story? I was in North American Spine Society in 2016. I didn't know then what I know now because, you know, this knowledge didn't come to me like immediately. It took year after year after year, slowly kind of seeps into me like what is going on. At that time, I was just starting to ask questions like something is going on, something's not right. So I got up in 2016 in North American Spine Society in front of 1,000 surgeons. I said, I have 6 papers that says the screws don't work. So what is going on? So one of the professors in the panel said, well, we did our studies later on. We found that they work great. And I didn't want to fight with them. They're very famous, very well-known surgeons. You know, I wanted to tell them, well, why didn't you publish those data? You know, I was like, you kept it for yourself. So I didn't want to get into argument. So I sat down and not a big deal. 20 minutes later, I was in line to get coffee. I was talking to a representative from a company, and then he introduced me to the gentleman behind me. And then he turned around to him and said, Dr. Aslie doesn't like the screws. And he turned around to me and said, oh, you're the gentleman that made that comment. Well, I just want to tell you that everyone is welcome to their opinion, but you're very wrong. I said, it's not about me. It's not about me that I'm right or wrong. It's about research. Our own research says that stuff doesn't work. Maybe, just maybe they're trying to tell us something. He said, I know. I published those papers. Those are my patients. I'm like, yeah, what's your name? He told me his name, and he was right. I had the papers in my hand. He was the fifth author. So the fifth, in a line of authors that are listed, he was the fifth author of the second paper. He said, see, that's me, that's me. I'm like, okay, well, let's read your paper. At the end, this is what it says word for word. Based on the current data, we do not recommend routine use of screws in spinal fusions. He looked at it again, then he said, no, that's wrong. And he walked away. I know, that's what I'm dealing with.
Interesting.
Right.
So with all that being said, what do you use? I mean, what is the safe or proper way to do spinal surgery if these screws don't work?
Right. That's a big question. That's the question that everyone asks me. Well, this is my answer. I use screws. I have to use screws because they are the standard of care. I use them every time I do surgeries. Why? Because if I do the surgery and there's something wrong and the patient goes to the next doctor, that's the first thing they're going to put their finger on. The Dr. Aslie didn't use the screws, and that's why, because that's their standard of care. I'm not going to practice my own medicine. That's when I will get into trouble. So I am practicing the standard of care, but I want to change the standard of care. And the changing the standard of care, we have to change it from the bottom. We have to change the complete training. 1 year is not enough for anybody to even get some sort of an idea of what's going on. I mean, 1 year, you just basically try to be a safe surgeon. That's all. You really didn't learn anything. You just want to make sure you're not injure the patient. And then you're on your own. It's just crazy.
So, well, is there anything that a patient needs to do or ask a surgeon before procedure, or steps that they should take in order to have more success?
Well, I've thought about that quite a bit. What do we do immediately? There's really not much you can do immediately. Why? Because I mean, we are what we are. We've been trained that way. This was taken a long time for. But what my goal of writing this book, literally, I tell you what was my goal of writing this book. I want the patients to start asking questions to the doctors, because doctors we have taken it for granted. This is not even a topic that they're even thinking about it. I remember one time I got in an argument with a professor from University of Michigan, and I told him, I said, there's so many papers that said these screws don't work. He turned around to me and said, what are you talking about? We showed these screws work a long time ago. And his partner on the side said, we never did. And so what has happened is that, and I go to these lectures twice a year. I've been going to these lectures since 2001. Every time I go to these lectures, professors get up and say, there's plenty of evidence that shows screws work. Then I go to the next lecture, there's plenty of, so what has happened is this: somebody got up in like late 1990s and said, oh, there's plenty of evidence. So some guys watched that lecture, they went next time, they got up and said, they're relying on that first case. There's plenty of evidence that shows screws work. Then this thing got a life of its own. So it's kind of just went down the road. So every time you go to a lecture, we've already assumed that these screws work beautifully. So they're not even aware of a problem. So, but if they do their research, if they do their homework, they'll realize that all the paper says that it does not work. Why? Because companies don't want to come out, because that basically cutting off all their income. So they're down, so they suppress all that talk and all that stuff. They don't want this to come out. It is crazy. So what I recommend for patients is get a second opinion. That's the first thing you can do. But unfortunately, when it comes to screws and what we are suffering in the world of spine surgery, unfortunately, I don't think we're going to be able to fix it ourselves. My goal is, by writing this book, patient starts asking questions, and hopefully the surgeons would start saying, like, maybe there's a problem, and I think investigation with the FDA or Senate might change something. But other than that, we are set into using the screws for the rest of our lives. And I wrote it in my book, if we don't do anything, we are here to stay. We're going to use those screws for really no benefit, and we're not going anywhere. There's not going to be any progress. Decades
Mhm.
from now, 50, 60 years from now, we're going to do the same exact thing. Because when I go to these surgeons and I question the screws, just question them, they want to tear me apart. Their attitude is that screw is as good as it gets. There's not going to be anything more. And I'm like, wait a minute. Let's think about that. Let's think about that. You put the screw into the vertebra. Well, vertebral motion is a rotational. The backbone, does not slide back and forth, does not slide up and down. It rotates, meaning that the motion that the screw has to stop is a rotational motion. Therefore, when it fails in toggle, not pull out, because the vertebrae doesn't go back and forth. Well, screw is not a proper device to stop toggle. It can't stop toggle. I was 6 years old when I realized that if you want to take a screw out, you don't yank on it. You toggle it and it will come out. I was 6 years old.
Mhm.
And then not only that, you put the screw into cancellous bone. So vertebrae backbone is not a solid block of wood. It's not like a cement. It's almost like a shoebox. The outside shell is a cortical strong bone. The inside bone is what we call cancellous spongy bone. So when you put the screws in, that's where you get your purchase. You get it from a spongy bone. And as we get older, that spongy bone really just melts away in a way.
Mhm.
After 70, you really got nothing. You just got like a sponge, basically. So I tell my colleagues, say, you tell a screw to do something that's not made for, you give him nothing but spongy bone, then when the research comes back and says it doesn't work, you don't want to accept it. It's just, it's this travesty. It's beyond logic. Let's put it this way. Is that
Mm.
crazy?
It is crazy. And I think if anybody got, if there's one message that can come from this episode, I think it's that everyone should question everything, whether that's coming from, on this podcast, we do talk a lot about like natural medicine stuff, holistic health. Um, question that stuff and question conventional medicine and question it all. Like you should always be asking questions, maybe looking into research yourself, looking deeper into what really works and what doesn't, and also seeing how clouded everything can be when it even comes to literature, even and what's out there and what people are saying and referencing. I think is a really, really important thing for people to realize instead of just trusting someone because, like, oh, it's a white coat or oh, it's this person. Like, I trust them because of a title or a paper or something. Like, it's really, really important to have people understand that. And yeah, I've even had, like, you made me think a little bit ago when you were talking about the paper being not even technically published. Like I have supplement companies reach out to me all the time to push their supplements, recommend them to people. And I 100% look at the studies. I do not recommend anything I've never used or don't believe in. And I have also had people try and they send me papers and they're not actually published papers yet. They're like in the testing. They're like, oh, this product does this and this. And I look at it, I'm like, no, you didn't send me a published paper. Like I don't actually see the evidence here. So yeah, like I
See,
said,
that's
yeah.
exactly what I'm talking about. That is how we should operate. That's
Hmm.
it. Our our legion is to our patients, not to enrich ourselves. Use our position to enrich ourselves, and that's what some of the surgeons do. I mean, I in 2020, I came to my office one day, and I had the Spine Journal. The Spine Journal is our Bible, basically, and the lead article was disappointing. The lead article said, this is word for word, undisclosed conflict of interest is prevalent in spine literature. I mean, that's not me. This is our journal saying that our data is tainted.
Mm-hmm.
And
Wow.
that's exactly, I have been approached by companies, and I told a few of them that, hey, look, this stuff doesn't work. I want to hear something interesting, and I tell you what that means. So the question is like, well, how do these companies control the thing? This is what happens. This is exactly how it happens. There was a surgery called XLIF that became XLIF, XLIF, that for the fusion in the lumbar spine, instead of going from the front, you go through the side. So this surgery became available right around 2004, 5. I was the first surgeon to do it in California. Maybe not Southern California, Northern California for sure. I think I was the first guy that actually did that surgery in California. So, and now that surgery is a standard of care. So when I started doing that surgery, in about a year or so, I had quite a bit of experience. So the company asked me to come and give a lecture to these, other surgeons that they're trying to learn that product. Well, they told me to present like 10 surgeries. Well, I had 9 surgeries that everything went great. I had one surgery that I had problem with. And basically the prosthesis I didn't put in the right place. And I realized during the surgery, but I couldn't take it out. It got stuck and I ended up breaking it. So I turned to myself. I said, shall I present it? Shall I not? And I said, you know what? If I'm there to teach these guys, that's how you learn with the bad surgeries. That's how people learn, not the good surgeries. So I went and I presented that. The first 9 surgeries was wonderful. Then I showed that one. And man, they got on. They 2 of the surgeons they start attacking me. You didn't do this right. I'm like that's exactly why I'm presenting. This is a morbidity mortality. This is the M&M I'm presenting. My mistake.
Mm.
So, anyways, and they were like, okay, no, we get it. Okay, thank you and stuff. And then that company never contact me ever again.
Ah,
Right, right,
yeah.
right.
Wow.
So this is what happens when we go to these conferences. And I've said that I've gotten in front of thousands of spine surgeons, and I've said this: when we go to these conferences, all these leaders of the field show their best surgeries, best outcome, most beautiful X-rays, and we go to these conferences. We think like, wow, everything works great. And then we come back and do surgery on our patients. Our patients end up in pain management and, screws breaking and everything. And so I told them in front of like 1,000 spine surgeons, we've created an alternative reality for ourselves. We've created a matrix that everything works. And that's because of the companies, because the companies don't want you to go show your problems, because that's the first thing that somebody's going to ask, like, what did you use? What was the equipment that you used? And they don't want that.
Mm-hmm.
And that's how these companies have influenced us and have a grip in the world of spine surgery. And that has to stop. We have to be more real in terms of what we do, what works and what doesn't work. And,
Mm-hmm.
the problem is multi-layered. Like one of the things I complain about, I don't want to complain about, I don't want to throw people under the bus, but what happens is that a good chunk of the famous surgeons, the surgeons that are very good, technically very good, they have PAs. They are very busy. So they have PAs to manage their office. Well, what happens is that once you have a PA, guess what? You're not going to see the patient very often. I took care of a patient from one of the towns in, let's say, Nevada. I don't want to go any further. Uh, he had a surgery and didn't go well. He came for me to second opinion. He was telling me that if you put my patient in a lineup, I could not tell you who he is. I never saw him. I saw the physician's assistant all along. He came and introduced him to me 5 minutes before the surgery, and I never saw him again. So what happens is that if you are a surgeon that you're busy, technically good surgeon, but the problem is that you stop learning. You become just a technician that does the surgery over and over and over, and you don't truly understand what the surgery is doing to your patient. So, so the whole, it's this unfortunate situation. It just really, and as I said, these instrument companies have a grip into the field of spine surgery. This grip needs to come apart. This cannot go on like this. As long as these instrument companies have such an influence in the specialty of medicine, we're not going to have a true progress.
Yeah.
And that's what I want. That's my goal with my book, is for people to start asking questions, writing letters to their representatives saying, like, we heard something like this going on. What's this all about? Why don't you look into this?
Mm-hmm.
Right.
Absolutely.
Because it's not going to come from the our own comrades. It's not going to come from our own ranks, because the training has been, for 5 years in general orthopedic surgery, they beat it into our head, becomes part of our DNA, that answer to any problem is a screw.
Wow. Well,
Exactly.
it's crazy. I know we got to wrap up here soon. Do you have time for a couple more quick questions?
Do you have questions? Sorry.
Do you have time for a couple more questions?
Absolutely. Absolutely.
Okay. Do you have any tips on how people can maintain healthy spines before they get to the point of needing surgery or even therapy?
That's a very difficult question. Why? You know, well, there are so many layers to that. One is healthy bones, let's say in the elderly, when you get older, when you are getting older, nutritionally you're deficient, actively you're not active, then you start losing bone mass and you start getting these compression fractures. And that's when people start getting these humps and they get to this twisted spine or so. So routine exercise and a healthy diet, that's definitely a must. Weight is important. What I tell my patients is that body is like a flagpole. If you have extra 1 pound in your gut, guess what? Your back muscles got to pull you back with 1 pound. Otherwise, you're going to fall forward, right? But both
Mhm.
that weight and the pull from the muscles, they both pull down on the spine. So if you lose 1 pound in your gut, you take 2, sometimes 3 pounds pressure off your spine.
Oh,
So
wow.
the weight is very important. Right, right. So those are the things. Now, let's say a healthy guy, he wants to keep his back healthy. I always listen to chiropractors saying that you got to strengthen your core, you got to strengthen your core. And that's true. You need to do that. But that's where me and the chiropractors kind of diverge. Why? Because when chiropractors say you got to strengthen your core, what I understand from is that if you build muscle around your spine, then you have a better balance. Therefore, your back gets stronger, meaning lifting heavier weights. Problem is that those discs holding your entire body, and everything you weight, lift, or whatever you do goes right through that disc, and that disc doesn't share the weight with anything around it. So you might be strong, you might be able to lift a weight, but that disc have a mind of its own, and you cannot make it stronger so they get injured less often. I don't know if that's you understand or not. What I'm trying to tell you is that not lifting heavy weight is the most important thing to have a healthy life, and that's basically comes down to your job. Let's say your job is being a mechanic. You have to lift these transmission to do certain things. You work at a warehouse. You have to lift these 50-pound bags constantly. Uh, that is when you put your back into jeopardy. So you got to have a job that doesn't put too much pressure in your back. And basically, it comes down to lifting. That's how you hurt your back. I mean, you can kind of feel uncomfortable, like driving a long distance or so, or chair or the bed. They can cause muscle spasms and you'll have some discomfort. But actually, hurting your back, it always comes down to lifting. And that's basically your activities.
Mm-hmm. Yeah, that definitely makes a ton of sense. I personally I have a standing desk because I work from home. So I like to I mean, obviously that's not for my lower back, but it's more for like, so I'm not hunching over as much, sitting in a chair all day. I have the ability to stand up straight and really, really focus on maintaining like that integrity of the spine. So that when I'm older, I am not super hunched over and have that challenge with that part of my back. So that's one thing that I do specifically.
Sure, I
Um,
love Varidesk. As a matter of fact, that's something that I recommend for my patients. Any position, well, the question is like, which position is better for your back? Sitting,
mhm.
any position for extended period of time is going to cause you discomfort. So,
Yeah,
uh, sitting, standing, taking a break, changing up, that's the most important thing, right?
absolutely. Are you open to doing a 5-question speed round?
Absolutely.
Okay. What is one thing that you do daily to maintain good health? Just it could be anything.
Routine exercise. I try to exercise at least 3 to 4 times a week, but I try to add here and there small things like I go on walks with my wife around, in our neighborhood or so. So routine exercise by far is the best thing to do to keep yourself healthy for all aspects of your health.
Okay. What are 2 impactful books that you've read?
Oh boy, that's a difficult question for me because uh, the books that I've read, I mean, I don't remember. But they're mostly textbooks, so I don't know how
Oh,
to answer that.
you're a true doctor.
Right, right. Oh
Uh,
my God, I'm so embarrassed of that
no, no,
question.
it's okay. Um, we'll go to the next one. What's your favorite hobby?
I'm a pilot. I
Oh,
have a Bonanza, airplane, a single engine. We travel quite a bit with my family, so aviation is my passion. Um, Everything I do, every time I have a 5 minute break or so, I'm reading about aviation accidents, different planes or so. So aviation is definitely my blood. I just can't get enough of it.
that's super cool. If you could live anywhere in the world, where would it be?
California, Sacramento.
Where you live?
Northern California for sure. I mean, Northern
Okay.
California is such a wonderful place. I mean, you talk about the Mendocino County, you talk about Santa Cruz County. Those are just most beautiful places in the world. I would not change it for a world.
Mhm.
Definitely wonderful.
Okay. The last question. First thing that comes to your mind, don't think too much about it. If you could leave the listeners with one tip that they could start doing this week to help them live a healthier, happier life, what would it be?
I think a healthy diet and healthy weight, that's no question, that's the most important thing. And it got to be something that they like.
Hmm.
Weight is a very difficult topic to talk to my patients. Why? Because they've already gone through it. People have already, it's not something that they just found out. So they've gone through ups and downs or so. Um, so it's a very difficult topic to talk about. But unfortunately, physics is physics. I have to talk to them. And I always tell them that, they have to find a diet. Some of my patients say, well, I can't exercise because of my back. And that's true. But at the same time, I tell them the most important component of a good, healthy weight is diet. And the way I explain it is that you got to have a diet that you like. If you try something that you don't like and it's going to give you good results, it doesn't matter. You're going to, at some point, you're going to give it up and you're going to go right back to where you started. Something that helped me quite a bit in my own life. Now, that's me. Everybody can be different. I tend not to eat meals anymore. I don't eat breakfast. I don't eat lunch. The reason that I eat dinner is because I want to be with my family, with my daughters and my wife. But that doesn't mean that I'm hungry. No, hunger is a horrible thing. I'm eating snacks throughout the day, like, a little bit here, a little bit of there, a little fruit there, a little fruit there. So I'm never hungry. But at the same time, I don't sit down and gorge like, a plate of this or pork chop of that. So I would say finding a diet that you really like and keeps you healthy is absolutely the most important thing in life. I have a lot of patients that they've come to me, they had some problems, and then they found something, they lost weight, they were so much happier, they were so much outgoing. Of course, the back pain, well, a good chunk of the back pain got better. So, hey, you can't argue with that.
Mm-hmm. That's amazing. Well, thank you so much for being on the show. Do you want to share where people can find you?
Absolutely. I have a website called Sacramento Spine Treatment Center, and my book called Corporate Spine is available on Amazon, and it's very cheap. It's only $25. And the first four chapters, I've written it to teach patients in terms of what spine surgeons face, how we evaluate our patients, and teach whatever I learned 20 years of practice to my patients. And it's written very easy read. It's written for patients, not written for, so you don't have to be a doctor to read it. So definitely, I tell people, I say it's your duty to write this book because what's happening in the world of spine surgery is happening on other fields of medicine as well,
Mhm.
and it has to stop. It just can't keep going like this. So, and I have a website called corporatespinebook.com. Corporatespinebook.com. I've prepared some videos that actually, if people don't want to read the book, they can go and each chapter, I've prepared videos to show the most important parts of that chapter so they can watch those videos if they want to.
Amazing. I will put the links for all of that in the show notes. And yeah, this was a very eye-opening, interesting conversation. So thank you so much again.
Thank you. Thank you for giving me a chance.
Thank you so much for watching this video. Don't forget to like this video and comment, letting me know what you enjoyed and what you want to see more of. Also, please subscribe and hit the notification bell so that you get alerts when new content is coming out and you don't miss any videos. And just a quick reminder that this information is for educational and entertainment purposes only. It is not intended to diagnose, treat, or cure any illness or medical condition. Please consult with a qualified healthcare professional before making any changes to your diet, exercise routine, supplements, or medical treatment. If you're looking for a functional medicine practitioner, please reach out to me. And thank you again for watching, and keep striving to become your healthiest, happiest self.